Good morning, everybody. My name is Shannon Echeverry, and I am the director of the Turner Senior Wellness Program. Thanks for joining on this rainy Wednesday morning. So here we're excited because we have a very timely topic here, obesity treatments, what to ask my doctor, with Dr. Arisika. Can you say DeLeo?
Yes.
Okay. Okay. So we're happy to have her here to talk to us today. And so just a couple of things before we get started. So this is being recorded. So if you do want to share it with friends and family after the fact, in about a week, it will be on the Turner Senior Wellness Program website, which is mishmed.org/TSWP. Also, we do have an option for you to ask some questions today. So if you see at the bottom of your screen, there is a Q&A section. So please, as the presentation goes along, if you have questions, put them in the box. And at the end of the presentation, I will ask those questions to our presenter. Also, we have some different ways to make this a more pleasant experience. We do have a captioning option. So in your screen, you will see a CC button to show captions as this goes along. And then also there is a view section on my screen. It's at the top right, which shows how you can view the presentation. So you can play around with the settings if you want to see just the slides. You could go to shared content only, or you can do gallery if you would like to see our presenter on the side. So play around with that for whatever is the best viewing experience for you. So with that aside, I'd like to pass along the presentation and I hope you enjoy and hope it's informative. All right. Thank you so much.
Can everybody hear me well? Shannon, can you hear me
Yes.
well?
Thank you.
Okay, perfect. So good morning, everyone. Thank you for being here today. I'm Dr. Patricia Arizaca Di Leo. I'm really honored to speak with you about this topic that I'm really deeply passionate about. My presentation is called Obesity Treatment and What to Ask Your Doctor. I'm a clinical assistant professor of internal medicine at the University of Michigan, and I am a diplomate of the American Board of Obesity Medicine. This means that I specialize in helping people navigate the best medical treatment available for weight management, including lifestyle changes, medications, and surgical options. My goal today is to give you the knowledge and confidence to have a meaningful conversation with your doctor about weight management. Either if you're exploring options for yourself or for a loved one, I really hope this discussion empowers you with practical science-backed information. So let's move on a little bit and start the presentation. Okay, so let's start with the definition of obesity. So what we know as of now, what the physicians use in the clinical setting is having a BMI more than 30 will correspond to an unhealthy excess of body fat. These days, the use of a BMI only is debatable because there is a lot of information coming out about how inaccurate a BMI could be. And there is other measures to measure increased body fat. There is different technologies like body DEXA composition or bioimpedance. I can tell you a little bit about this later, but this requires tools. But there is other ways that we can also kind of identify if it is unhealthy accumulation of body fat. At the office visit, checking abdominal circumference or abdominal circumference hip measurement ratio is also another way to do it. And we know that obesity results from a mix of genetic, metabolic, and environmental and behavioral factors. Sometimes when I'm discussing it with my patients, we call it the genetics and the epigenetics of obesity. We know that it's now recognized as a chronic disease, and it is not just a lifestyle issue. We know that affects about 40% of the US population. So what is the health impact of carrying increased or excessive body fat? Increases the health risk because of, for many individuals, having been diagnosed with obesity. It can increase the risk for heart disease, high blood pressure, stroke, type 2 diabetes, sleep apnea, arthritis, or even certain type of cancers. So what else increased body fat can do? It can definitely reduce mobility and quality of life. And if it's left untreated, it can even shorten your lifespan. The good news is that even a modest weight loss, like 5 to 10% of body weight, can significantly improve different measures, like improving blood sugar, blood pressure, and improving your cholesterol levels. We know this based in trials and research. And going back a little bit about obesity being a chronic condition, remember that this is not a character flaw, it's a medical condition. It is influenced by hormones and metabolism. And we know that the body tends to defend its highest weight. And that's why losing the weight, but mainly keeping the weight off, it's very challenging. We do have different tools, and the approach right now it is as a long-term management, like any other chronic conditions like high blood pressure or diabetes. So the holistic approach of weight management means seeing the patient as a totality. With modern medicine, we have developed a new tool for treatment of increased body weight, and it's prescription medications, but food can be a prescription, or lifestyle changes could be a prescription as well. But the use of anti-obesity medications are usually alongside lifestyle modifications, physical activity adjustments. And this is extremely important, especially for individuals that they're already showing evidence of organ dysfunction that is actually caused by the excess body fat accumulation. So we'll talk a little bit about options for prescription treatment for weight management as a tool, and we'll dive in into the latest or newest medications. So we have the oldest medications. Most of these medication or some of them work as appetite suppressants or have other mechanism of action, but work mainly in the brain, in the chemistry of the brain. From 1969, we have phentermine is one of the oldest medications. It can act as appetite suppressant. It is the commonly known Adipex. And recently in 2012, it was approved combined with topiramate, that is another medication used for other reasons. By putting them together and studying them, it show about 7% of body weight loss. We have another one called Contrave, approved in 2014. It is a combination of older medications used for other reasons, like naltrexone and bupropion, and also works in the brain, helping to control emotional eating and cravings. We do have Xenical Ally, that is the name for over the counter, and Orlistat comes with prescription from 1999. And pretty much prevents absorption of some fat with meals. These have to be taken properly, have to be taken in a very timely manner. The amount of weight loss is usually about 2%. The problem with this medication is can cause significant side effects, mainly oily stools when eaten with high fat meals, and also even fecal incontinence. So let's talk about the newest medication. So this is under the umbrella what we call incretin-based therapy. It's a new class, new quote new, and I'm going to tell you a little bit why it's not necessarily new. But the incretin-based therapy includes the GLP-1 receptor agonist and the dual GLP-1 GIP. I'll tell you a little bit more about what this means. It's definitely a game changer for obesity treatment. There is other medications that are hormonal treatment as well that are used for rare cases of obesity. And other medications used off-label, like metformin, probably you've seen it. It's used for patients with prediabetes. It can give you about 2% of body weight loss. Remember that is used off-label, so technically not FDA approved specifically for weight loss, but it helps with patients specifically that have prediabetes associated with increased body weight. So the indication for the use of anti-obesity medication in general is having a BMI more than 30 or a BMI more than 27 with weight-related or health-related problems like diabetes, hypertension, sleep apnea, fatty liver disease. One caveat, it is the BMI cutoff depends of ethnicity. Sometimes it varies. So that's something to discuss with your primary care physician. This is intended to work with lifestyle changes, and it is not a replacement for the other interventions that we do when it comes to weight management. Actually, the studies have shown that this medication achieve the highest percentage of weight loss when it's combined with dietary recommendations and changes in physical activity. So the incretin therapy, or these are hormones that are released by the GI tract, by the gut, and have an effect on the amount of food that we eat, the volume. It signals the body to regulate appetite and also blood sugar. These medications mimic the hormones that we do have, that is the GLP-1, and also, like I said, the other one that is fairly new with an indication for obesity is the GLP-1 GIP. So pretty much what you're going to feel with this medication is it makes you feel full sooner, make you feel less hungry. The mechanism of actions are several, but mainly works in the brain and in the GI tract, slowing down gastric emptying and reducing food cravings. So they were originally developed for diabetes, but then study at higher doses. It showed that it can produce significant amount of weight loss. Patients, for example, that were in the study that got semaglutide approved. Semaglutide is what you guys probably know as Ozempic or Wegovy at the highest dose of 2.4 milligrams in patients without diabetes was able to get them to a 15% of body weight loss. We know in patients with diabetes that weight loss tends to be a little bit lower, but in general, it is a significant amount of weight loss. The other one, it's called tirzepatide with the names of Mounjaro for diabetes or Zepbound as an indication for obesity, and now with a new indication for sleep apnea. These medication show at the highest dose about 20% of body weight loss. Um, and it is one thing to notice is that with this percentage of weight loss, we are getting closer to the amount of weight loss that bariatric surgery can get. So it's definitely a breakthrough in the management of obesity, and it is shortening the gap between surgical intervention and medical management. Both of them, semaglutide and tirzepatide, are once a week injection compared to liraglutide that is a daily injection that is kind of an older generation. So the benefits of this medication, besides the weight loss, definitely have improvement in blood sugar, especially because they were initially studied and approved for management of diabetes. It helps patients with prediabetes as well. It lowers blood pressure as long as it produces weight loss. It can improve cholesterol levels as well. Many patients report reduced appetite as well as fewer food obsessions. There is this term that probably you've heard called food noise or food chatter. And patients report that there is a significant decrease in this and makes it easier for them to stick to changes in the dietary habits that they haven't been able to keep in the past when they have tried. Other benefit will be improving joint pain, increased mobility, and increased overall energy. Common side effects of these medications, because we know it works in the GI tract, in the gastrointestinal system, side effects are going to be mainly gastrointestinal, like nausea, sensation of fullness, in a few cases could be vomiting or diarrhea, acid reflux as well presents. Not everybody is going to get the side effects. They usually improve over time, especially if the titration of the medication is done slowly and the dose is adjusted with your physician's supervision. And there is a specific schedule about how to do the titration, but it can be slower if you are having problems tolerating the doses. There is very rare risk, including a very rare type of thyroid cancer. It's called medullary thyroid carcinoma. And patients with this history should avoid or shouldn't use this medication. And an emphasis in the fact that not all thyroid cancers are the same. This is specifically a red flag when it comes to medullary thyroid carcinoma. There is rare cases of pancreatitis that it should be monitored as well. But in most patients, if the health history, the medical history, if discussed with the physician, the benefits outweigh the risk because the side effects can significantly improve over time, especially if it's monitored by your physician. So if your doctor decides to try a medication, any anti-obesity medication, it is always important for your physician, the nurses, or the medical assistant to teach you and to make you feel comfortable about how to use the medication. Sometimes you will require a closer follow-up, education. If you are afraid of needles, maybe some reassurance or showing you the size of the needle. Those things are going to make you feel a little bit more comfortable. And then supervision and also follow-up is very important. Technically, the definition of a medication not being effective is losing less than 5% of body weight in a period of time of 3 months. At that time, the doctor needs to reassess and see if there is a change or there is a need for a change of medication. And these medications. And this is something to remember that many times patients don't have a conversation with their physicians about, or they're confused, or there's a misunderstanding. Technically, these medications were studied to use as long-term. So if we think about this condition as a brain condition or as a brain GI condition, we try to regulate the brain chemistry and the connection between the hormones. We do not completely rewire the brain. So that's why this medication is a tool added to the other changes. But when we discontinue the medication, sometimes the food obsession, the extreme hunger, the extreme lack of fullness, all of that could come back. So as a long-term condition, we always need to think about long-term treatment, not necessarily with a specific medication, maybe switching between one and another, but there is some type of long-term treatment that needs to be things. So don't think about these medications, either the injectables or the orals, as a quick fix or as a very short period of time. It's not impossible to come off of the medications, but the your body weight had to be reset significantly. You need to keep up a certain amount of dietary modifications. Your eating style cannot go back to the one that kept you at the highest weight. So all of these are conversations you need to have with your physicians, but it's important to remember this. So when it comes to the other components, nutrition is very important. We forget about the importance of protein and high fiber grains. Ideally, we should be limiting processed food, especially with high sugar or high fat contents, especially also saturated fat. Portion control sometimes is very important. Usually the consultation I have with patients, it takes me about 1 hour because I need to talk to them and do a recall of their dietary habits. Many times it's not about eating um, unhealthy food or maybe food with a high amount of calories. Sometimes it's about portions and not necessarily, or sometimes it's about frequency of the meals. Consistency is very important as well. The data comparison in studies about the diets that work better for weight management, and in reality, all of them will work exactly, will achieve or will give you the benefit as long as you can stick to it. So if you will start a diet or a dietary modification that it doesn't align with your lifestyle, it's better not to do it because it won't be sustainable. Working with a registered dietitian can definitely provide you a personalized guidance. When it comes to physical activity, the standard recommendation is about 10, you know, 30, about 150 minutes of exercise in 1 week or 30 minutes about 5 days a week. But in patients that start with a very high body weight, I'm always very careful in advising very slow pace increase of physical activity. If you have a high body weight, your body, your joints are supporting are carrying way more than what they're used to. So if you are recommending a high intensity exercise from the beginning, it can lead to injury. So starting with something as small as a 10-minute walk and build up slowly, it will definitely will be much better. At some point, I always remind the patients to incorporate um, uh, strength training exercise. It is very important to keep your muscle mass, especially if the weight loss is going to be significant. Sometimes we cannot tell the body if you are going to lose only body fat or muscle mass. So keeping a strength training exercise is very important. There is certain activities depending of the weather, of course, that you can do outside, that it can also be considered moderate intensity exercise. But the most important thing is to start slow and build up over time with the guidance of your physician or your personal training or somebody that can definitely help you with that. Um, the other part that is important and sometimes helps patient quite a bit, it is accountability, self-monitoring, and then set a realistic goal. And this is something that I spend quite a bit of time with patient. Having an unrealistic goal, it only leads to frustration and maybe feeling kind of defeated in some way. So we always try to establish small goals, short-term goals, and reassess every time when the patient has achieved those goals. The behavioral part or the mindset or what is leading to increased frequency of meals or increased volume of meals many times have to do with emotional eating or some sort of coping mechanism. So working with a behavioral health specialist or working with some sort of like in-person or online behavioral recommendation, it is important. And many of these programs or even working with your physician works because there is the support and the accountability. A lot of patients feel better or like they feel that they can do the changes better when there is somebody that they can go back if they're feeling that they're not achieving the goals. It can get reassured because this is a very emotional journey, especially if they have attempts in the past that had led to failure multiple times. There is another intervention that is always important to discuss with patient because bariatric surgery or weight loss surgery is the only treatment right now that we can say it can give you long-term remission. Of course, there is the chance for recurrence like any other long-term condition, but with bariatric surgery, we can get up to 30% of body weight loss. And for patients that have extreme severe complications from increased body fat, this can be a life-saving treatment. There is different type of interventions when it comes to bariatric surgery. The most common one right now is a sleeve gastrectomy. It's less invasive than what gastric bypass used to be, but they still perform Roux-en-Y gastric bypass and duodenal switch that is a more extensive bypass that sometimes can lead to a higher percentage of body weight, but definitely more complications. The adjustable gastric band, probably you know this procedure quite a bit, but it's not used as much as it used to be in the past because technically it is a restrictive kind of intervention, not necessarily a metabolic intervention like a sleeve gastrectomy. And by metabolic means that when they do the sleeve gastrectomy or pretty much shaving 75% of your stomach, it leads to changes in hormones, in the appetite hormones, in the fullness hormones. So it's not necessarily the mechanical restriction for the bypass surgery is also the changes in the hormonal levels that it happens. So when you go to the visit with your physician, what are the questions? What are the topics that you want to know or learn or ask? Um, First of all, your physician needs to know about your complete history. It wouldn't do you a favor to prescribe a medication without knowing how it's going to interact with other medications. But also it is important for your physician to know what have you tried before, what it worked for you, what it didn't work for you, so we do not repeat something that it will not fit your lifestyle. Knowing how these medications work, having a specific expectations, knowing about the benefits and the potential side effects, it's important. Maybe not necessarily spending the whole visit discussing it, but your physician can provide information that you can read at home and feel more comfortable. The other question is about long-term use and long-term commitment, as well as maintenance. For how long do I take these medications? What are the side effects I need to watch for? How often are we going to be communicating in order to do the adjustment necessary? Especially when using the injectable medications and even with the oral, having a close communication with your physician or having access to the practice in order to discuss any new side effects that we were not aware of, it is important. So at the beginning, especially just getting a prescription and not having some sort of guidance will not be the best. Always discuss about lifestyle programs that I can follow. Like I said before, this is a very patient-centered, very catered treatment that we start with patients. So not all of them are going to respond to a specific recipe. So there is patients that have a different approach when it comes to dietary style, like for example, patients that prefer to do a Mediterranean diet or low carb diet or paleo diet. It is very different, and we have to find what it really works for you. When it comes to physical activity, like I said, start slow, knowing your history regarding joint injuries or history of knee replacement or history of advanced arthritis, it will make a difference in the type of recommendation that we're giving. And then also as if your primary care doesn't feel comfortable or doesn't know too much obesity management, ask for a referral to a board certified obesity medicine specialist or an endocrinologist or even a bariatric bariatric surgeon if when you discuss it, you feel that that's something that will be better for you in the situation that you are on right now. Um, if you have concerns about safety of the medication, including cost, insurance coverage, especially with the new weight loss medications, that's something that you can discuss with your physician. But I can tell you, based in practice, being a primary care as well, that many times we're not completely aware of what is specific insurance if it covers or doesn't cover these medications, or what are the requirements or the criteria. So doing your own research, investigation, your due diligence, it will be important when you come to the visit. So you can be on the same page and have more knowledge about access to these medications. Um, like I said before, establishing goals, how much weight loss are you expecting me to lose, or how much weight loss I want to lose? I've never guide weight loss based in a number or even a BMI. This is mainly about improving your metabolic profile, making your lab work look much better, improving your blood sugar, having less stress in your joints. We're talking about percentages because that's the way weight loss was studied, or it continues to be a study. For example, 5% of body weight loss can improve pre-diabetes or blood sugar. 10% of body weight loss can definitely improve joint disease. Even a little bit more than 10% can improve fatty liver disease. So we know what is the percentage that it will be giving you certain benefit according to the your health profile, your circumstances. Um, how to approach the inability to lose weight. When do I need to go? When do I need to come back and talk to you? I'm talking about the physician about what is the next step. There is nothing wrong about switching from one medication to another. Or switching from a type of dietary intervention compared to another if things are not working. That's what the reassessing the condition and reassessing the response to the treatment is very important. Bring up any concern with your physician about safety of the medication or anything else. Like I said, will be important. If you don't know too much about nutrition, ask questions about it or ask to be referred to a nutritionist. Things to remember, again, I want to emphasize this obesity, or at least knowing as a clinical obesity. There is another term that we are continuing to investigate and to know more about, that is a preclinical obesity. And we can talk a little bit more about this. But having clinical obesity as a definition of increased body fat that can lead to organ dysfunction, or having abnormal labs, or already feeling the increased weight that you're carrying. Um, it is important to remember this is not a lifestyle choice, or it's not a character flaw. We know that patients that can get to some degree of weight loss can definitely improve lifestyle in general. Um, um, Bariatric surgery as an intervention or as a more invasive procedure requires commitment. So talk about what are the implications of having bariatric surgery. Talk about medications that you have tried in the past that haven't given you any benefit. And then talk about these newest ones if it is the best for you. Um, we are not we're not always going to be a candidate for a specific medication. Sometimes there is medication that we should not take based on chronic medical conditions, or there is probably something that would work better based on what has led to the accumulation of extra weight. So talk to your physician about it. This is an ongoing process. This doesn't happen from one day to another. There were a lot of circumstances and events that led you to where you are right now. So it's going to take some time to your body get adjusted to a new body weight, to slowly get to you want to get, and also to reset your set point. That is what we call to this number that our brain and body are used to, that always going to try to come back to. Um, Having regular follow-ups, track your progress, do the adjustment accordingly, will definitely improve the success. So obesity can be treated at any age. It's never too late to improve your health. There's definitely advances and there is breakthrough with the current treatments that it will that has proven that leads to more percentage of weight loss and improvement of health in general. Remember always that medications are an added tool, but there is other changes that need to be done. And any changes to that are done, they need to be or they should be long term. We need to make sure these changes are sustainable, or at least have an idea of how we're going to keep the changes. And that's why I always remind my patients to make it suitable to your lifestyle. First step is always have a conversation with your doctor about this. There's a lot of information and misinformation in the internet, in social media, in different applications. So if you do have questions, ask your physician. And if your physician doesn't know too much about it, then ask for a referral to somebody that have more expertise in obesity management. I think that's it. Any questions?
Thank you so much. That was so informative. Yes, please, if anybody has any questions, please put them in the Q&A. Otherwise, I have a couple of questions for you.
Yeah.
Wouldn't mind answering them that I had along the way. So, and I know that you mentioned it briefly, but could you talk a little bit more about BMI? I know you talked about how that's not really the best indicator, but what else might be considered, considering that BMI is not necessarily the most accurate?
Yeah, so there's different studies, different definitions, and different ways that we are approaching this. There was an article published by Lancet a few months ago where they're trying to define obesity as a clinical obesity in the sense that the increased body fat is actually causing some harm in the body. We want to be conscious about overdiagnosing or medicalizing increased weight. And, we want to be aware and conscious about body positivity and if we feel comfortable with our body as well. And it's never the intention um, to label somebody as, obese or clinically obese. But the tools that we have right now are, weight is one of them, and BMI is only one parameter. Having a abdominal circumference measure that is the easiest that we can do in the office, it will give us information about the increased body fat in the abdominal area. And the reason is because we know that increased body fat in the abdominal area, it correlates with metabolic disorder. It correlates with increased fat tissue in between the organs, in the and then by increased body fat in between the intestines, sitting in the liver, around the pancreas, this definitely is going to cause some problems with organ function. So we know patients that have an increased abdominal circumference and a high BMI, they also will start showing signs of fatty liver disease, prediabetes, problems with blood sugar. And mainly because of a BMI will not tell you if your muscle mass is way higher than your body fat. The other tools that they will be a little bit better to characterize that will be a body composition. If you know about, how it's done, the DEXA scan for osteoporosis is a machine. It's not nothing interventional in general, not very invasive, but it's a series of x-rays. So with the different software, this DEXA scan machine can measure and differentiate between muscle mass and body fat. It comes with a report, and then it gives you an idea where you at. I would like to use this often as an initial assessment and then as a follow-up to compare. Unfortunately, it's not covered by the insurance, and it could be a little bit expensive, so I don't have the tool. But what I usually do with my patients is check the weight, assess the BMI, check the abdominal circumference, and check their labs. I have patients with a BMI of 35, for example, and they don't have any symptoms. Their joints are fine. Their quality of life and mobility is normal. I do their labs, and their labs are perfectly fine. There is no metabolic disorder. So we can say, okay, we are in the preclinical obesity state. And this is something, well, the patient will remain for a long time, but we cannot deny the fact that increased body fat, if we prove that actually the abdominal circumference is elevated, it can be a precursor, or it can lead in the future, several years later, to some sort of dysfunction. But that doesn't mean the intervention right now have to be aggressive. It could be, just a follow-up, just maybe increase a little bit physical activity, but having other tools more than just the BMI, it will avoid over treatment, over diagnosis, over labeling, or including stigmatization, I think.
Thank you so much. That was really helpful. I appreciate that. So we do have one question in the Q&A. So the question is, what efforts are being made to convince health insurance companies to cover the new medications for non-diabetic patients?
Yeah, this is a very hot topic. And believe me, I deal with this every single day of my practice. We definitely have different organizations that are continue advocating for it. We as physicians continue giving feedback about it, but unfortunately, this has to do with the cost of the medication, the cost of producing this medication, and the deals between the pharmacy formulary and the seller. We know that these medications in other countries, specifically the brand name medications, are definitely cheaper. So the way that it is regulated here is just, maybe not it's not the most fair for patients. But if the patient have a diagnosis of obesity that is causing some organ dysfunction and it is affecting their life, definitely it should be covered. So we are advocating for it. There is several organizations advocated for it. There's multiple studies that are showing more and more how percentage of body weight loss leads to improve quality of life and health. So I would say that's what we're doing. And I'm pretty sure there is a group of physicians also that are lobbying with their congressman. They're going to, ask for it. But the scenarios rapidly changes when it comes to health insurances. So it's really hard to know exactly how it's going to go.
Yes. Thank you. Appreciate that. Um, what about since this presentation is specifically for older adults, I appreciate you saying that it's never too late to do something to improve your quality of life. Is there anything in particular for older adults, either other conditions that they have or other factors that you think should be considered for that population specifically?
Yeah, I mean, there's several of them. I will say one of them is polypharmacy. And then, at certain time in our life, there is, unfortunately, we develop more chronic conditions. So knowing exactly what medications you are taking and what medication we're going to use for intervention, any anti-obesity medication, the interaction with them, and if you started to lose weight, have to adjust this medication is extremely important, especially, for example, if you're starting to lose weight and instead of needing three blood pressure medications, you only need two. if that is not adjusted, or if it's not, a new prescription is given, or somebody tell you to stop one of the medications, it can lead to low blood pressure. It can lead to kidney dysfunction. So knowing the interaction and knowing when to take you off of certain medications, the patient has diabetes and is losing weight. Sometimes they don't need more diabetes medication. So not doing the changes, or not changing things, sometimes it could lead to problems and risk for your health. So that will be one of them. Muscle mass preservation is another thing. When we're younger, we tend to retain more muscle mass. We're more active. Our hormones work different. It's natural that with age we start losing percentage of body mass. So if we have a rapid weight loss and our protein intake during the weight loss, or when we are restricting calories, is not appropriate, you can have a high risk of losing too much muscle mass. If you think about muscle mass, it helps you to support your joints and your body frame in general. So in patients that at older, that are older, it can lead to increased falls, it can lead to increased joint pain, it can lead to not having good support in the knees. So supervising the intake, supervise the protein intake, and supervising the weight training exercises, it is important to consider at this age. Um, what else? Other things in general, like, how active you are, what will be the likelihood of you being able to start doing more physical activity, especially if you need a hip replacement or a knee replacement. So addressing all those issues, because each part or each component is going to be important in your journey. So if we cannot use the physical activity as much, we cannot put that much weight on it, then we should prioritize other components of the weight loss journey.
Thank you. Yes, it sounds like there's a lot of things to consider, and part of that leads into my next question. So I know that these new medications are becoming really popular, more mainstream. Celebrities are using them, so they're kind of blowing up. If you had to look ahead, I mean, do you see this? Do you think that these medications will have staying power? Do you think that we're getting a little bit of a blip just because it's new and exciting? What do you think the different paths that this could take for people long term?
So that's one thing that I wanted to mention. Maybe I didn't have time. These medications technically are not new. The incretin therapy, or the base formulation, the GLP-1 medication, glucagon-like peptide, were initially approved for the management of diabetes. And this goes back as far as 18 years, when the first treatment for diabetes, one of the first one was something called um, Bayeta, that is a hormone that is a GLP-1 hormone. That was 18 years ago. There is one of them we still use that was about 16 years ago. It's Victoza, that is the daily injection. So the um, the way the medication is injected, the frequency of injection has been improving, and then maybe modernized or being a little bit easier. But in general, we've used these medications for about 18 years, the basic formula, the basic molecule. It keeps getting a little bit more like it's smarter in some way, because we used to use it once a day and now it's once a week. They are even thinking about once a month. So it's getting a little bit um, easier to use. But so that's one fact about when I explain to my patients, especially the ones that I feel they're going to significantly benefit from it, they are not new medications. We know the risks, we know more about, what do we need to avoid or what do we need to take into consideration, but they're not new. Number two, we cannot deny the fact that these medications have an effect not only in hunger control, but they're realizing that there is more and more benefit when it comes to, fat distribution, liver function, even brain function. There is some patients that have history of food addiction or even addiction or other type of addiction where suddenly by using this medication that went away. Patients with chronic alcohol consumption, where some studies are using these medications for decreasing the cravings for alcohol or the desire. And that goes back to the pleasure center and how it affects the brain receptor. So in general, I consider these medications very useful. And I don't think they're going to be just, a momentary kind of like treatment, but I'm definitely um, convinced that the treatment should be prioritized, that it should be used in the right clinical setting for the right reasons when the patient really is a good candidate for it. But there is no denying at all that these medications are very effective. And there is some studies that even have proven that reduce cardiovascular disease in some patients with already cardiac disease. So they're very good. They're beneficial. Always used in the proper way.
Thank you. And we do have one more question in the Q&A, and then I think we'll wrap it up. So this individual says that they are on Medicare plus Blue Cross Blue Shield traditional as supplemental, and they have a meeting with Weight Navi tomorrow. And the question is, how are these initial meetings coded for insurance? And do you find these meetings are covered by insurance or full pay by patients? Is there any particular language that this person should be using to try to make sure that these are covered?
I will say before, if you're afraid that it's not going to be covered, it's better to talk to the person in the office if they need to obtain a prior authorization or it's going to be covered technically. An obesity medicine specialist, it could be part of internal medicine practice or a family medicine practice. So we usually code this under the not under a subspecialty, but it mainly under primary care visit. It is extended visit, it's a longer visit, so it will be coded accordingly to the complexity, but technically it's a primary care visit. So that usually is covered. The visit with way navigation program in U of M, probably that's what the patient is referring to. It's a 60-minute visit, so it's a very complex visit, and it goes through all the different um, interventions and the options and all of that. But I definitely don't know exactly if there is any restrictions that the insurance have that I've know based on experience. Medicare and having a supplemental insurance will cover the visit, but it's better to double check with registration.
Perfect. All right. Well, I don't see any more questions. Thank you so much for your time. This was very informative. And as I mentioned, this will be on our website so that way people can refer back. And I really appreciate it.
Of course. Thank you for inviting me.
All right. Have a wonderful day, everybody. Bye.